Dear colleagues, hello from Istanbul. I would like to present a case to you from these Corona days. It's pretty difficult case and difficult approach, but I hope it's going to be a pretty educative for you. These patients, young patients, around 34 years old, came to the office due to fracture of tooth number 1.5 and 1.6. And we did carefully evaluate the case with my prosthodontist colleague. And after clinical and radiological evaluation, we decided to extract this tooth and put an immediate implant and immediate CAD/CAM restoration. As you can see here, tooth number 1.5 only has a buccal wall and have already been treated with root canal treatment long time ago. And tooth number 6 is a little bit worse position than tooth number 1.5. There's much more damage, and also there's a huge caries on the distal side, as you can see here on the X-ray. So in this particular cases, if possible, sometimes I extract the tooth and put the implants immediately in the same session. In the molar area, due to the root anatomy, sometimes it's not possible, sometimes possible. If you have a root anatomy, like on the left side, like a fusion of the roots, sometimes it's not possible to put immediate implant at the same session. But if you have a root anatomy like on the right side, it means that due to the root anatomy, you have enough bone support in the interradicular area, so it allows you to have a good primary stability. Of course, if you are talking about the first molar, you have to also take into consideration between the sinus floor and the bone amount underneath. But on the left side, as you can see here, when the root anatomy is like this, then in this case it's not possible to extract the tooth and put the implant at the same session. In this case, it's better to postpone it. In this case, the stage approach. So, first of all, I extract tooth number 1.5 and put my implants, as you can see on the left side. Then I sectioned of tooth number 1.6 into 3 pieces. So I separated mesiobuccal and distal and distabuccal roots and the palatal roots, and I made a little bit mobility with my elevator. Then I enlarged the hole, entrance hole, and I did my osteotomy, and I put my implant as well, as you can see on the right side. So this is why I'm doing this technique before extraction the roots. I need to support these roots during my osteotomy in order to not to lose the bone support in the interradicular space. After the finished my implants positioned, then I'm extracting the roots and doing my augmentation. It is 50-50 autogenous bone and 50% of xenografts, as you can see here. And I made a little bit, I put 2 stitches in order to get smaller entrance for the area. Now patient ready to go my prosthodontist colleague's box. Then we put two thigh base and scan body. When scan it, we obtained two temporary IMAX screw retained crown and placed in. This is immediately after the surgery. And as you can see here, these crowns are not in the occlusion. We left around 1 to 2 millimeter space in order to avoid the overload to the roots. Then let it be healed like this. Then this is when the patients come in on the left side, and when the patient leaves the office like it on the right side. This is post-op 3 months. As you can see here, healing is pretty nice. Now patient ready to go to the permanent crown. This is the situation after 3 months, sorry. And as you can see here, the healing is pretty okay. Now we can go for the permanent IMAX crown. This is the area, healing area. So after the scanning of the crowns, we create a new two separately screw retained IMAX crown, and the crowns in the position. And as you can see here, the emergence profile and the soft tissue and everything is preserved due to our technique, and patient is pretty happy about the results. And this is what I like, this kind of intervention is it's one session and atraumatic, and you are definitely preserving the emergence profile of the permanent crowns. Thank you for listening. Hope you enjoyed. Bye-bye.